great pleasure to welcome Dr. Indy Gill, who needs no introduction and is talking to us about clinical trial endpoints.
Thank you. So let's talk about some trial endpoints for focal therapy. The goal here is to have a discussion about, does focal therapy have a role in the management of men with clinically significant prostate cancer who desire treatment? And the answer, obviously, is yes at this meeting, of course. But for this to move forward, three things have to happen. Number one, all of us have to agree that the data presented work from our perspective. In other words, they are meaningful to us. Secondly, the FDA has to sign off on it. And thirdly, this trial would then have to have data that are relevant subsequently when 5 to 10 years later, those data become available. Obviously, it's been a difficult thing to do. We've not been able to do it so far. FDA approval for oncologic pharmaceuticals is based on overall and cancer-specific survival, which does not work for low intermediate risk cancer, prostate cancer, given its long natural history. And comparing novel and established therapies with randomized trials in the US has been very challenging, and here are some of the trials that just have not made it to the finish line. However, the landscape is changing. For contemporary focal therapy trials, there's a lot of activity going on, much of it in Europe, although the US is also beginning to enter this. And so the things are looking up, and as you have seen already this morning in the various conversations. FDA approval for low and intermediate risk prostate cancer in the United States, nada. Current treatments are all either grandfathered or have just a tool claim, not cancer specific. Here's a list of some of these: robotics and radiation, cryo, therapeutic ultrasound, IRE, MR-guided laser, in-office laser. And you can see the majority of these are grandfathered or have basically a tool claim. Looking at three specific things for the FDA indications, approvals for low and intermediate risk. Robotic devices can be promoted as a surgical tool, but not as an effective cancer treatment. Therapeutic ultrasound can be promoted for focal ablation, but not for cancer ablation. And cryoablation can be promoted for cancer ablation, but not for focal ablation. So, we obviously have a mishmash. And legitimately, companies can bring publications that have used their technology and make a case for you to use it. The goal of all cancer treatments has to be, of course, eliminating lethal disease with metastatic potential. Of course, in the prostate arena, preservation of function is paramount as well. In active surveillance, as we know, we don't treat disease that doesn't need to be treated. Radical therapy eliminates the entire gland if the risk is high, and focal therapy tries to eliminate only the threatening disease while sparing function in men in whom active surveillance would be too high risk. Paul Klotz from the FDA proposed this straw man trial comparing surveillance with surveillance plus intervention, primary endpoint being local progression, secondary being avoidance of local therapy, with post-marketing requirement to assess delayed harm. The issue here is that basically this was for low-risk disease. Most of these don't even need treatment, and will treat 100% of men to benefit a small minority. Equally, the issue with this trial design is that it does not expand the utilization of active surveillance, and is at high risk of being irrelevant by the time the data are coming out. So the goal of focal therapy, as we all agree, is not to replace active surveillance, but to enable it. The unmet need here is to control clinically significant disease, defined as GG2 or higher, while delaying or eliminating radical therapy and thereby maintaining quality of life. This would indeed provide men with clinically significant benefit. So at this point, intermediate risk and low risk disease, what is the 3-year conversion rate to radical therapy? For low risk prostate cancer, at 3 years, 64% convert to radical therapy. 64% for low-risk disease. Intermediate risk disease, 93% as it should be, and these as it has been. And these data do provide a literature-based target on which we can potentially plan some trials. Favorable and unfavorable intermediate risk disease stratification does need to be revisited. Men diagnosed today are likely to be stratified into higher risk disease based on the MR-guided biopsies. And you can see that little schematic in the bottom where, compared to previous years, today there are more high-risk cancers being found. And therefore, the focal therapy sweet spot has changed accordingly. Earlier, it used to be higher end of low risk and favorable risk disease. Now it's favorable, intermediate, and the lower end of unfavorable intermediate risk. And that's where the money shot is. Future-proofing this trial then is critical. Otherwise, you do a lot of work, and as was done for the low-risk cancers, and by the time this, these difficult studies are completed, I mean, we can't even use the data. And it has to be the least burdensome approach with reasonable follow-up that we all in this room and others, the urologists, have to agree as to what is going to be good enough for initial approval. How many years of follow-up for cancer control and delayed reduction of harm, and the 10 to 20-year data are just not going to work for us. So as regards future-proofing, how to identify the patient, the appropriate patient. For grade group 1 disease, active surveillance is the way to go. Focal therapy, not really. And showing clinical benefit versus active surveillance is just not going to work. Not realistic. For grade group 4 to 5 high-risk disease, radical therapy is the way to go. And these patients do have significant risk as regards disease outside the prostate and metastatic potential. This also is not a realistic option. Grade group 2, active surveillance is an option, but focal can have potential benefit in some patients. Yet to show benefit, we'll need a large number of patients. For grade group 3 disease, radical therapy is the standard of care. Focal therapy does have the potential to give clinical benefit, but not without some risk, and will face some challenges with the FDA. They'll want to have long-term data. So indeed, if GG2 and 3 is where we are targeting, the intent of focal here would have to be to eradicate pattern 4. Risk stratification would have to maximize likelihood of focal therapy success, which means only a focal amount of pattern 4 disease. The breakpoint between favorable and unfavorable intermediate risk is helpful, but not really a definitive breakpoint. And the focal therapy inclusion factors should include only a little bit of focal, a little bit of pattern 4, that's non-diffuse, clearly defined targets without extra prostatic extension. Biopsy-based endpoints are relevant for radical therapy. Randomizing focal appropriate men to radical therapy is just going to be difficult, at least here in the US, given that folks can go elsewhere and get focal therapy. Comparison to active surveillance, challenging. Many men don't need treatment. And single-arm trials do have precedence in the literature for other diseases. We want to delay and prevent radical therapy, and we want to be able to document objective progression on biopsy grade and decrease morbidity, continence taking precedence over erectile dysfunction. So how would we design something? We would have, the goal would be to convert GG2 and 3 to grade group 1 or NED, thereby making the patient eligible for active surveillance for 3 to 5 years. And herein, the radical therapy conversion rates would be similar to men who started off on active surveillance to begin with. In this manner, we would have eliminated clinically significant disease and delayed the need for radical therapy and its morbidities. This would indeed be a clinical benefit. Patient population would be GG2, GG3, unilateral or bilateral. We can discuss this. MR fusion biopsy would be essential. PSA less than 20. MRI should have, 2 or so biopsy-confirmed pyroid lesions without extra prostatic extension. What are the pathologic parameters, the biopsy parameters? We can discuss it. What % cores positive? What % core positivity? How much pattern 4? We can discuss and debate. MRI can help eliminate or decrease the higher risk of these GG2-3 patients, no extra prostatic extension, etc., that would be allowed. And treatment strategy, we have to be able to, that's one of the beauties of focal therapy. You can redo it without paying too much of a penalty. So how many of those would be allowed? And additional treatment for out-of-field recurrence also to be discussed. Primary effectiveness endpoint would be freedom from failure. It would be a composite endpoint that would have absence of GG2 or higher disease, absence of systemic disease, absence of radical or salvage treatments. Primary safety endpoint would be functional benefit, and we could prioritize incontinence over ED based on patient preference, and longer-term follow-up would be needed to assess delayed harm. So to conclude then, the field has advanced rapidly and significantly. We all recognize overtreatment is not a good thing. The endpoints, though, for regulatory approval have been elusive. FDA, to their credit, is reacting favorably and is really facilitating innovation by being reasonable yet appropriately stringent. And they are really looking to folks in this room and others to give them guidance on how to drive focal therapy forward. We do need to be pragmatic. Single-arm trials, it may pass muster initially with the FDA, but getting into guidelines is going to be somewhat of a challenge. And these are just some of the thoughts that I wanted to articulate in trying to move this thing forward. Thank you.
Thank you very much, Dr. Gill. I'm sure we'll have some questions from the floor. Just a question for you, a challenge really. I think you set out there that we should be able to show that focal therapy has no worse conversion rate to radical treatment than active surveillance. But I'd say we should be better than that. We should be trying to be better than active surveillance.
Could you repeat I didn't fully understand.
So I think, and maybe I misunderstood,
yes.
that you proposed a comparison of sort of active surveillance alone for the rates of conversion to radical treatment versus focal therapy. But I think we ought to be aiming higher than that. So in our focal series, about 3 to 4% of men have radical treatment. In our surveillance series, it's probably 25%.
So indeed, I agree that it has to be a higher aim than just for active surveillance. I agree with that. Yeah.
Okay.
Any more questions? No?
We're already running late, huh?
Right, we are.
Thank you.
Thank you very much. Very thoughtful.
Okay, my pleasure to introduce the next speaker, Professor Klotz. He's going to talk about the MRI visibility versus invisibility implications on cancer biology, aggressiveness and screening post-treatment patient population. Thank you.
Thank you, ladies and gentlemen. So there's been a lot of discussion around this topic, but not really addressing it directly. We all worry about the missed cancers, the criticism of focal therapy, multifocality is common, MRI doesn't pick up all lesions. How significant is that? We just heard about the concerns about any pattern 4 being present as being clinically significant. That's the kind of rubric that defines clinical significance in the literature. And I'm going to kind of try and throw some darts at that. So first of all, definitely MRI misses cancer. This is one systematic review that shows in the graph on the left there, total, targeted, and systematic, the target in the middle. So you can see that consistently, if you do systematic in addition to targeted, you find some additional cancers. And this concern about invisible cancers drives a lot of intervention. It drives systematic biopsies in men having targeted biopsies. It drives systematic biopsies in men who have negative imaging. There's pushback on focal therapy. We all know about that. and it also creates a lot of patient concern in the informed patient who worries that he may have untreated occult cancer. So what's the biological significance of these, and to what degree can we use imaging as a risk stratifier? Something like 15% of men with a negative MRI have grade group 2 cancer that is not visible. The visibility is a function of size, obviously, and conspicuity, and this is determined by the tightness of cellular packing, the quality of the lumen. As grade D differentiates, the lumen either becomes poorly formed or disappears. There's some subtypes that have lower conspicuity, mucin secreting, higher water content, less restriction of diffusion. But what I really wanted to focus on is that there's recent data, and this is all just in the last few years, that MR invisible tumors have different molecular genetic aberrations than visible tumors, and those molecular aberrations that characterize the visible tumors are also the molecular aberrations that drive invasion and metastasis. And the implication of this is very powerful. It means the term clinically significant as defining any pattern 4 being present is probably not appropriate for these MR invisible cancers. So just some of the molecular genetics. This is a quick overview. This is from earlier this year, radiogenomic analysis linking the patterns that you see on the right, T2, DCE, et cetera, with gene expression. And there's absolutely no question that various aspects, this is the radiogenomics field, of MR visibility are associated with different molecular aberrations that are oncologically very significant. This is an incredible paper from about 5 years ago. You see the heat map on the left of visibility versus invisibility. There's major stratification of gene expression according to visibility or not. And there's the conclusion at the bottom. On the right, you see some of the genes, whether it's cell cycle regulation, mitosis, invasion, et cetera. These genes associated with visibility are also the genes associated with aggressive cancers. The conclusion of the paper, genes involved in cancer progression influence MR visibility. One more paper from this year related to tissue hypoxia and the genes associated with tissue hypoxia, and again, MRI visibility associated with this well-known feature of aggressive cancers. And finally, on the molecular side, this term nimbosis has been defined. This is from the UCLA group, which means genomic instability, hypoxia, and clinical aggressivity. Nimbosis means gathering of stormy clouds, the nimbus clouds. And essentially, the conclusion of the paper is at the bottom. These data suggest a confluence of aggressive molecular and microenvironmental phenomena underlie MR visibility. So what all this data is showing is if you can't see the cancer, it really is important. That is likely to be, at least from a molecular perspective, an indolent cancer. And just one more from that group showing that genes associated with hypoxia, with SHLAP1, which is a molecular marker of aggressiveness associated with MR visibility. Nimbosis drives MR visibility. So I think I'll skip that one in the interest of time, makes the same point. So then what data is there about the clinical correlate of this more benign molecular phenotype associated with MR invisibility? So here's one paper. This came from Memorial Sloan Kettering last year. This is an amazing paper. 1,449 patients with clinically significant prostate cancer having surgery, and the outcomes. So, of course, there's surgical intervention. But the bottom green line in each one of those graphs is MR invisible. The red line is MR visible. The brown line is mainly PIRADS3. You can drive when have you seen curves with a difference in progression, metastasis, mortality like that? Like, it's amazing. The MR invisible cancers are clinically indolent cancers is the powerful message from this study. Mortality is in there. You can see in the bottom right, major difference. And this is another one. The difference is not as great, but still it's consistent. 672 men on surveillance, so no surgical intervention here. And you can see the MR invisible, much more favorable outcome managed with surveillance, lower risk of progression in every respect if the lesions were invisible. And then just, this is the well-known Hugeson screening study that was published New England Journal last year. 1,800 men randomized between targeted plus systematic and targeted only. And the remarkable thing about this is that the relatively few patients who had only systematic biopsy positive for grade group 2 or higher. So in other words, negative targeted, positive systematic, all those patients had basically minimal grade group 2 disease. They were all managed with active surveillance. The implication being that that group of patients out of 1,800, even amongst those who benefited from the systematic biopsy in terms of diagnosis, did not really benefit in terms of their management, still managed conservatively. So just some other thoughts. There is literature, you're probably aware of it, that in the patients who have negative targeted positive systematic biopsies, it's usually from the penumbra, the shadow, the peri-index lesion biopsy, and it's almost always ipsilateral. So it suggests that a lot of these positive systematic negative targeted biopsies has to do with off-target, just failure to accurately target the actual lesion. The second point is the prevalence of this. I mean, 1 million biopsies a year in the US. The kind of public health implications of dropping systematic biopsies is really very considerable. This is not a trivial thing. And finally, the MR field is on fire. The progress in this area, and I'll just outline a few of these. So this is machine learning. The blue star in the middle is the performance of skilled MR radiographers at predicting Gleason 4 prostate cancer. The machine learning, there's the ROC curve, significantly better. So machine learning is going to have an impact here in terms of accuracy. And then this is just a summary of what is happening in this field and the kind of radiogenomics and further analysis of patterns, kurtosis imaging, restrictive spectrum imaging, the verdict approach, which basically drills down into intra versus extracellular volume, the Zoom DWI, arterial spin labeled, which is a kind of vascular approach, luminal water imaging. The details don't matter that much, just to say it's getting better. So the MR visibility and accuracy is improving. Is this ready for prime time? That's debatable. I think it is. There's unmet needs. We need to confirm that these uncommon, invisible, aggressive cancers will actually show up. So the idea is you don't worry about them now because you can't see them. They're molecularly indolent. If they are significant, they're going to pop up on the MRI that you do in 2 or 3 years, but that needs to be validated. Further analysis, the radiogenomics, the field is still in its infancy. We need to interrogate existing databases for more natural history data because it's relatively few studies, although they're pretty convincing. A thing I'm particularly interested in is micro-ultrasound and PSMA invisibility. Is that the same as MR? Does it have the same implications? We have no idea. What about PIRADS-3? Equivocal, doesn't really move the needle, but how do the genomics compare? And what about visible grade group 1? Are those actually worse cancers? Is that a marker for adverse disease biology? So finally, I think the evidence has really accumulated in the last few years that these MR invisible lesions are different from visible lesions. They should be thought of differently, treated differently, and basically we shouldn't worry about them too much. They're somewhere around 6 to 15% of cases. In most of these missed cases pose little threat to the patient. Patients obviously prefer imaging to biopsy as a way of following their cancer. and it has many advantages, this kind of image-based strategy in terms of the burden of care, cost, psychological benefits, less diagnosis of insignificant cancer. Thank you.
Thank you very much. Any question from the floor? I have just a quick comment.
Yes.
It's just a prediction a bit. What do you think that is going to come, the improve on imaging? Is going to come from MRI, from ultrasound, or from PET scan or fusion combination techniques?
Well, let's say all three. But so I think, MR, I think perhaps, so one question that I wonder about is, as MR gets better, so there's all these new technologies, is it going to result in a kind of overdiagnosis phenomenon like more stage migration? We've seen that over and over as imaging technologies get more sensitive. PSA clearly has a role. We've heard about that earlier today. What does a PSMA negative study mean? And, I don't know the answer to that. And I think high-resolution micro-ultrasound, to me, looks very appealing, although it's complementary to MRI. It's not going to replace it, but it can replace some MRIs. Occasionally you see a lesion on ultrasound that you miss on MRI and vice versa. Yes?
Yeah, I had a question. Does anybody know what we know about a multi-parametric negative MRI being followed with a biparametric or a two-phase MRI later? Is that okay? Do we even know that?
There's probably people here in the room who can answer that better than I can. My understanding is that the biparametric for most patients is just about as good. The role of the contrast is more to differentiate cancer from non-cancer than actually as to whether or not there's a lesion present. So I don't think the visibility issue should be contrast dependent, but I stand to be corrected.
So we do have some data from our sort of 1,000 men MR-led active surveillance, and people can progress on any of the sequences. So we keep all the sequences, including contrast. You can progress first on contrast.
To keep things on time, we have, because it's lunch break right now, I want to make sure we're fair to the speakers, and then we can talk about some of these things over lunch.
Okay, thank you very much. Thank you.
Dr. Taneja, pleasure to introduce Dr. Taneja for the index tumor theory. Thank you.
All right, thank you. So this talk, of course, overlaps a lot. Laurie's talk was really a good setup for this because, of course, MRI is how we define index lesion. And, Art asked me to give this talk. I sort of said, what were you looking for? And he really felt a lot of the young people joining the field may not be familiar with the idea of the index tumor theory and how it's evolved the field. So I went back into my coffers, my old slides, and I found index lesion slides. So basically, index lesion theory is the idea that within a large number of prostate cancers that we resected historically, we found unifocal disease, or what was termed biologically unifocal disease. Most pathology studies show that 13 to 38% of cancers are truly unifocal. A large number beyond that have a dominant single tumor with relatively indolent multifocal lesions, similar to what would be found at autopsy. And this led to the assertion that prostate cancer treatment could be focused to one dominant area. And this sort of sits at the root of focal therapy. And it's important to recognize the goal of focal therapy is different. We know that the men we treat are likely to have residual cancer, so more than 50% probably have multifocality, and therefore it's not a Halstedian paradigm, which is what makes it hard to compare to prostatectomy, as you've heard. The goal is prevention and mitigation of metastasis and mortality, and the assertion is that you can do that through focal therapy. And just for perspective, the focal therapy, the index lesion or focal lesion paradigm was talked about as far back as 2007 by Dr. Scardino's group, and Scott Egner wrote this very nice review article on it back then. And it was really rooted in the simple observation that most metastasis comes from one clonal origin. So this was a study done by Steve Bova, which is often referenced in 2009. And what it was a study where they did warm autopsies on 30 men who died of metastatic disease. They did genomic assessment of the metastases and showed that the majority of metastases they had genetic heterogeneity, but they could be traced back to one clonal origin in the prostate. And so from that emerged the idea that if you could identify that clonal origin, you could mitigate metastatic risk. The concept of the index lesion or dominant relates to pathology studies which go far back from Memorial and other places, showing that the majority of disease in most patients resides in an index lesion. Non-index lesions are typically low grade. They rarely exhibit extracapsular extension. They're typically small volume. And ultimately, based on the study I just showed you, there was an editorial in 2009 by Hashamed that suggested herein lies the basis of a focal therapy paradigm. This was an abstract from UCL that I borrowed long ago, and it's still in my slide set, but it really illustrates it nicely. 100 consecutive prostatectomies, 22 of them had unifocal disease, much of which was low grade. 78 had multifocal disease, but about half of those were, as shown in the diagram, dominant single lesion with smaller secondary foci. And so it was concluded that about 50% of men who would have gone to radical prostatectomy would therefore be focal candidates. But of course, there are controversies. How do you define that index lesion? I'm not going to spend a lot of time because I think Laurie just made a very strong argument that this could be defined by imaging. But historically, this was the question, is really what you're seeing imaging. And there have been a number of whole mount correlative radical prostatectomy studies which suggest, hey, you miss a lot of significant disease outside the lesion. I think the problem with those is selection. There's no doubt there are a number of men with high volume disease that we wouldn't even consider focal therapy. So that's not a fair comparator. And it's also generally not described what the relationship to the index is. Is it within this umbra penumbra that Wayne Brisman wrote about, or is it truly multifocal disease? We've learned that most of the high-grade disease we miss is ipsilateral to the target, and therefore probably related to the index. But it's not always perfect. There have been mapping studies which have shown that within an individual prostate, you can have separate clones, all of which have lethal or metastatic potential, but metastasize in different patterns. One clone may be lymph node metastatic, one clone may be distant metastatic, and then it acquires increasing genetic heterogeneity over time. And we see this sometimes in our recurrence patients. So this is a small subset of my patients that I reported on a few years ago who had achieved longer follow-up after partial gland ablation. And I would just draw your attention to the two arrows. The men who have required retreatment, typically it's margin recurrence that we've not incompletely treated the index and we've retreated them early on. Whereas those that have required radical treatment, it's much later on when they emerge with more aggressive or multifocal disease. And that may represent that subset where we've underestimated what the true index lesion is. There's no doubt they're out there. I have patients in my own practice who have come back with metastatic failure. As examples, this is a patient 6 months after a partial gland HIFU ablation. The ablation looks good in the upper right. I think I even showed you this slide earlier today. But on the lower left, when you interrogate the margin, there's a small focus of residual disease that's been missed. I told you earlier that margin for focal index lesions needs to extend outside the gland. This is a patient I treated with focal cryoablation, lesion in the right peripheral zone. 6 months later, beautiful architecture, contour deformity, capsular retraction, biopsy benign, PSA declined. But then a few months later, he recurs with a nodule in the neurovascular bundle outside the prostate. And on biopsy, you can see cancer in the adipose tissue. So don't underestimate that the margin just has to be inside the gland, because a good number of these men have microscopic focal disease outside. So I think index lesion planning and treatment planning really relates to margin, as you've heard over and over again this morning. And that's where we should be focusing our efforts to improve outcomes. I showed you earlier that we did a study back in 2015 that really changed the way I practice focal therapy. We co-registered imaging to MRI and showed that all of our cancers could be treated within a 9 mm margin. Now, that's not always effective, and one of the reasons for that is that the way we measured this is with these green arrows, the Hausdorff distances. If you don't segment the lesion completely, you will underestimate the margin. So you're relying heavily on accurate segmentation for good margin. Otherwise, you're going to underestimate and not get all the disease. Let me skip past this. So we rely on biopsy and segmentation because cores outside of the target within the umbra penumbra might tailor the margin. So just like I showed you this morning, it's not just a concentric 10 mm margin. You have to extend it beyond those areas if you have systematic cores that inform it. Are there ways to improve margin? Well, this is a product that's recently been FDA approved for Avenda Health, and in disclosure, I'm scheduled to be the PI of their upcoming multi-center trial, so I listed that in the disclosures earlier. But this is a product that they'll be using in the trial, but is already available now. And basically, it's an AI platform that incorporates spatial relationship of the cores, pathology, MRI data, and PSA into a machine learning model to predict the margin. And it's been shown by Lenny Marx's group that when you use this, you can expand the margin appropriately with greater confidence to treat the whole lesion. This is an example where if you had just done a 10 mm margin, you would have missed the lower part of this tumor, whereas the IAI is telling you where to extend the margin. But of course, if you notice on the left, there was a positive core at the bottom, and that positive core, just as I showed you this morning, probably should influence the extension of your margin. When they've compared 10 mm ROI expansion to the AI margin, you can see that there's a bit of a greater complete margin. There's a greater likelihood of complete encapsulation of the margin using the default AI margin as compared to the 10 mm expansion. The final thing I'll show you is that we've been interested in intraoperative assessment of margin. The title is hiding there, but we've been working with a new tool called stimulated Raman histology, and we've developed a methodology where we take the core, we place it in a specialized glass tray, we scan a biopsy core with a laser, and we get a real-time histology image within 2 minutes that we can then use to determine whether or not cancer is present intraoperatively. We actually have built an AI platform which has 96% accuracy in telling us that. So here's an example of a patient we treated with cryo in a small trial we've recently done where we took a core from the target, proved it was cancer on the AI, planned our margin, and then intraoperatively biopsied adjacent to the ice ball, showing no cancer here, but cancer in this margin. Then we intraoperatively extend the ice ball and confirm negative margins. And when we've done that, we found in a very small early sample set that it correlates very well with the likelihood of negative biopsies afterwards. So intraoperative mapping, if you can real-time assess the tissue, may be another way to go. So in conclusion, to believe in focal therapy, you have to believe in the index lesion. In defining the index lesion probably still remains a challenge, but I think we would all agree visibility is a surrogate of significance. The optimal identification probably still requires biopsy data to map it, and radiogenomic signatures, as Dr. Klotz showed you, may be the future. I do think full treatment of the index lesion is a primary goal, and we can get better at mapping index lesions with improving image, AI-based planning, and some degree of intraoperative assessment. Thanks very much.
Thank you. Yeah. I think in view of the timing, Samir will, I'm sure, take questions over lunch. And our last talk of the session from Dr. Lebastchi, if you could come up. Great.
All right, thank you very much for giving me the opportunity to speak. I understand I'm the last person before lunch, so I'm trying to make it a reasonable time. So double tap or boost HIFU, why you need more. I have a couple disclosures. The most important, I'm a consultant for EDAP Focal and HIFU. I think that's relevant to this talk. What's the goal of focal therapy? The goal of HIFU or focal therapy is to treat clinically significant prostate cancer, but at the same time minimizing treatment-associated side effects. We have shown, other groups have shown as well, that there are good cancer control in the medium term. The need for radical treatments at 5 years is about 10%. The treatment failure rate ranges somewhere between 20 to 30% at 5 years. So, but similar to other surgical innovations and technologies, we constantly try to adjust our treatment, tweak our technique, optimize therapy delivery. So we come a long way when we talk about the evolution of prostate cancer treatment. In Baltimore, we started the open prostatectomy. It went over to radical prostatectomy, radiation, ultimately robotic prostatectomy, and focal therapy is the new kid on the block with very promising results. So, one slide back, sorry. So there are some causes, some biological causes for failures. So we might miss the extent of the tumor because of the treatment margin was not sufficient. It could be due to a heat sink effect from vasculature counteracting the thermoablative effect. Maybe suboptimal energy delivery. It could be patient factors, a lot of perirectal fat amount, or just device that there was not sufficient energy delivery, or swelling and shifting of the gland during treatment. Our group at USC has shown in the past that there is, Dr. Ukimura and Dr. Brew, my senior partner as well, Dr. Gill, have shown about 10 years ago already that prostate swelling and shifting during HIFU occurs. And these have implications for targeted focal therapy. We have shown that during HIFU, there's about a 13% volume increase, and the prostate is swelling up towards the pubic bone, about 6 millimeter shift. So, what's the rationale for boost or double tap HIFU? So the rationale is to reduce recurrence rates with boost treatment. So they're going to be more energy absorbed, leading to improved coagulative necrosis, sufficient high temperatures at more focal points, ultimately counteracting the shifting and swelling of the prostate that the patient experienced during HIFU. So I want to introduce two forms of HIFU boost. There's something we call the focal boost, where we treat just the target with a safety margin and overlying it with a hemiablation. Or we can do a more aggressive, that's what we perform at the USC, if we do a boost treatment, hemi square or hemiablation times 2, we perform a hemiablation and do another hemiablation on top of that. And what's the rationale again? So the single pass versus boost. So this is the prostate. We plan our treatment. This is what happens with the first pass. We treat the prostate. But what actually happens is that the prostate is swelling and shifting during treatment. By offering a second pass or a boost, we counteract to the swelling and the shifting during HIFU. This is another way to look at it. This is the prostate. These are our focal points that we outlined prior to treatment. The treatment happens, the prostate is swelling, so we use the same amount of focal points on a larger region ultimately. By performing a boost, we double the focal points, increase treatment, so logically the recurrence rate is going to decrease. So Dr. Mu and Dr. Ahmed from UK published on that. There was an exploratory study of dose escalation versus standard focal high-intensity focus for treating non-metastatic cancers. They used the Sonoblade machine where they use a double, I think a double pass is already the standard treatment. A boost is a third pass over the tumor. So the hypothesis was dose escalation of HIFU might overcome these biological causes I was introducing earlier and improve disease control rates. Over a decade, they included 162 patients and compared standard versus a dose escalation HIFU in a paired match comparison, and they looked into the oncological recurrence rate. So on the left slide, it's a busy slide, just showed that there was no demographic differences between standard and dose escalation HIFU patients. And those were basically the results. They were able to reduce the treatment failure rates from 31% to 19%. There was no significant increase in complications. This poster was published by a German group from the Martini Clinic. They used the Focal One HIFU machine. They included the same amount of patients, 164 patients, 7-year experience with HIFU, and what they performed, it's a busy slide, I'm going to summarize it. 164 patients included. They performed follow-up biopsies on 102 patients. They performed hemiablation on all the patients, and basically they found that there was about 7% failure rate in the treatment area. So I went and couldn't believe it, so we went there and looked at it. So in fact, they performed hemi square, so hemiablation times 2. And this is basically, these are the results. 164 patients they enrolled, grade group 2 in over 61% of patients. 102 patients had follow-up biopsies, a median follow-up of 54 months, about 4.5 years. The median PSA was 6, so the continence rate was 100%, and only a 7.3% failure rate, treatment failure rate. And again, all patients were treated with hemiablation times 2. So when it comes to HIFU, I think it's like money. More is always better. Thank you.
Thank you very much.
I think we do have a moment for questions, actually, because you've been very succinct in your talk. Thank you. Do you?
Yeah, thank you. That was a great overview. A couple of comments.
Quickly, please.
I see your description of why we're thinking that a double tap is important for the swelling. Are we noticing that it's an issue at the margins, or more like an under-treatment failure? Or is it really within the lesion? And have we established that that's the mechanism? Because in many ways, particularly as we go from the posterior to the anterior gland, I worry about confluence of the treatment voxel and things like that. And sometimes I wonder if the double tap is actually just like more of the Swiss cheese model of addressing the thing. And I think this is going to be important as we compare energies, because certain energies are going to be beholden to confluence efforts and things like that. Are we just overlying a mesh, addressing more energy, or is it at the edge, right? And I think that's important because this addresses what is an in-field failure and out-of-field failure. Because an out-of-field failure, which is a problem with treatment planning that we just don't see and we just don't aim at, is different than an energy failure.
Well, I think you answered your question. Basically, yeah, we don't know what it is, but I think Dr. Taneja was showing that some of these failures are around. What we noticed in our study to see about the shifting, we realized that actually the peripheral zone shifts more than even the transition zone. And since most of the cancers are in the peripheral zone, actually we're going to address those hopefully by doing it. We perform So most of the failures that also the German group looked into is periurethral, because we were very careful around the urethra.
I'd like to invite everyone to lunch. It's been a great morning, and we're going to start promptly at 1 o'clock. Thank you, everyone.